experience with the use of a dual mobility implant in primary procedures to prevent instability in patients at risk for dislocation. As you all know, instability remains a troublesome complication after a total hip replacement. Its prevalence is highly variable in the literature and has been reported ranging from less than 1% to 5% in the largest series for primary procedures. Factors involved in the occurrence of instability can be classified as factors related to the patient, factors related to the implant, and factors related to the surgical procedure. Dislocation is well known to be more frequent in specific demographic groups that have been identified and reported in the literature. Preoperative identification of the patients at risk for dislocation will lead the surgeon to preoperatively use all appropriate means to prevent the occurrence of dislocation, such as careful preoperative planning, choice of an appropriate surgical approach, and selection of the implant. This implant needs to provide some protection against dislocation. The goal of the present study was to evaluate the use of dual mobility implants for primary total hip replacement in patients at risk for dislocation. Here is a dual mobility implant. This implant has been first described and designed by Gilles Bousquet in France in 1976, thanks to the interposition of a mobile polyethylene component between the prosthetic femoral head and an outer metal shell. Such an implant provides two bearings, an inner bearing between the femoral head and the mobile polyethylene component, and an outer bearing between the polyethylene component and the outer metal shell. So we performed at our institution a retrospective study including 186 primary total hip replacement using a dual mobility hip implant between January 2000 and July 2003 in 181 patients at risk for dislocation. At latest follow-up, 18 patients, 19 hips, were lost to follow-up, leaving 163 patients, 167 hips available for evaluation. There were 99 females and 64 males. The mean age of surgery was 72 years old, the range ranging from 21 to 97-year-old. More than half of the patients were 75-year-old and more, and about 1/3 of the patients were 80-year-old and more. The mean clinical and radiographic follow-up was 40.2 months, ranging from 24 to 65 months. Here are the criteria we used to define the patients at risk for dislocation. These criteria have been clearly identified and published in the literature. Age of 75-year-old and more, female of 70-year-old or more, prior hip surgery such as femoral or acetabular osteotomy, failed hip fracture fixation, underlying diagnosis of femoral neck fracture, avascular necrosis of the femoral head, hip dysplasia, inflammatory arthritis, tumor of the proximal femur. Also neuromuscular disease, epilepsy, cerebral palsy, poliomyelitis, Parkinson's disease, myopathy, and cognitive dysfunction and alcoholism, and also American Society of Anesthesiologists score of 3 and more. Here is the distribution of the risk factors in this series, and here is the distribution of the patients according to the number of risk factors, of identified risk factors. 84% of these patients had at least 2 risk factors for dislocation. We use a single design of a dual mobility implant, the Saturn cup, which is an anatomically designed cup. The original design by Bousquet has been altered to improve both the range of motion to impingement and the stability. This implant was most of the time used without cement, 165 hips, and in 2 cases we had to cement this implant into a cage. We used most of the time an anterolateral approach. Clinical evaluation was performed using Harris hip score, and radiological evaluation was performed to detect and locate reducent lines and osteolysis. 24 patients died during follow-up, 21 of unrelated causes. 3 patients died directly because of the surgical procedure. 1 patient died during surgery because of embolism after femoral component cementation. 1 patient died of pulmonary embolism 3 days after surgery, and 1 patient died 3 months postoperatively because of a deep infection. Mean Harris hip score significantly improved postoperatively, and we did not observe any dislocation in this series. 6 patients sustained a revision procedure, 2 for deep infections, 1 sustained a Goldstein procedure, the other one had an early debridement with antibiotic therapy. Unfortunately, He died 3 months after surgery. One patient sustained a femoral component revision because of aseptic loosening. Another one had a femoral component exchange and open reduction and internal fixation of a prosthetic fracture at the femur site. And one patient was reoperated on because of a trochanteric non-union 7 months after the surgery. We had one cup migration secondary to a technical error. This occurred in a patient, in a 72-year-old female, which had a traumatic acetabular discontinuity that had not been fixed at the time of the index procedure, and this led to a revision of the arthroplasty 8 days after the surgery, with internal fixation and cementation of a dual mobility implant into a cage. For all other cases, we did not have any evidence of cup migration. Other complications included 5 intraoperative fractures, 3 at the acetabular site, 1 calcar fracture, and 1 trochanteric fracture. Other complications were non-specific. So in discussion, other options have been proposed in the literature to prevent dislocation in primary total hip arthroplasty. Elevated rim liners have been proposed, however, they raised concern regarding potential for increased wear and loosening. The value of larger head sizes is getting currently renewed attention, but it raised concerns regarding the potential increase of the volumetric wear and may lead to the use of alternate bearings such as ceramic on ceramic, metal on metal, or highly crossing polyethylene with a substantial increase of the cost. So this has to be weighed against the benefit. Bipolar implants have been proposed with low rate of dislocation. However, concerns have been raised regarding the potential poor functional results, and constrained implants has raised concern regarding the high risk for failures related to decreased range of motion, potential for impingement, and increased interfascial stresses. So in the present study, the use of a dual mobility implant was extremely successful in achieving stability, as no dislocation was observed in this population at risk for dislocation, where 84% of the patients had at least 2 risk factors for dislocation, and 44% of the patients had at least 3 risk factors for dislocation. We also could not observe any sign of component loosening. So the results of the present study are consistent with those reported in the literature with the use of a dual mobility implant. Farison in 1998 reported 144 unconstrained tripolar cups and 1 dislocation, and Obrio in a series of 100 dual mobility implants observed 1 dislocation. However, unlike the present study, the published series did not include patients at risk for dislocation. So the dual mobility implant raised concern about the wear of the polyethylene component at the 2 bearing surface. Because of the current lack of scientific data regarding polyethylene component wear, we do not recommend the routine use of these implants in primary total hip replacement. These implants are extremely efficient to prevent dislocation, and their use for primary total hip arthroplasty should be considered at the present time only in patients with a high risk for dislocation with limited level of activity. I thank you very much for your attention.